anybody out there who knows anything about stem cells and what your own body can do from a healing standpoint, you might have heard about PRP, Platelet Rich Plasma.
Yes.
Talk to me about that.
In the early 90s, Bob Marks at the University of Miami and we were doing a lot of bone grafts. And what we need to do with our bone grafts is stabilize them, make them sticky. Because a lot of times we couldn't get immobilization of the bone graft in large defects.
What do you mean? When you say the immobilization, they would move instead of stay in place?
Yeah, for example, if you put a bone graft into a socket, you have all the walls of an extraction socket to hold that bone in there. But if you're trying to build up a ridge, it's just a bunch of gum tissue holding that bone in there. And so in Europe, what was available was fibrin glue. They took from the tissue bank blood, they divided it through a centrifuge, the red blood cells, the platelets, the fibrin, that's what makes the scab sticky, the serum, okay? And they took the fibrin, essentially freeze-dried it, and that was available. So surgeons in Europe, if they had an incision, they could, instead of suturing it or stapling it together, could glue it together with fibrin glue.
Okay.
So we thought, great, we'll order some fibrin glue, we'll add it to our bone graft material and make it all sticky like a sausage, and it's gonna hold together better. We couldn't order it. The FDA said, well, that is blood that's from 600 or 1,000 donors all in a big vat because it's commercially made. And so if there's disease from one, it's gonna be in all of that whole batch.
Contaminate, yeah.
So we're not gonna allow it in the US because the US FDA is much stricter than is the rest of the world. And so we said, wow, we can't do that. So we were going to make our own sort of fibrin glue. In the operating room, and these are large cases, and so in the operating room, we took the patient's own blood, spun it ourselves, let the red blood cells migrate to the bottom, the serum to the top, and the middle layer is concentrated fibrin. And we took that middle layer from the patient themselves and added to our bone graft and made it sticky.
And I mean, so you guys were the originators of this.
Yeah. And what happened is it made it sticky, great for handling. That's all we were looking for. So we stumbled on this. What we noticed is the bone grafts where we use this, the bones seem to be twice as dense and mature twice as fast. Now that's something beyond just stickiness.
That's huge.
So then we started looking into it, realized that middle layer when we're trying to get the fibrin is we're also, because the platelets have the same weight and we're capturing platelets. So if you take a 10 ml test tube, spin it, and take all the platelets in 10 mLs and shrink it down to 1 ml, the same volume, we got 10 times the platelet concentration in 1 ml. And the platelets have growth factors in them, which makes sense. You get a tooth extraction or a broken arm or a paper cut on your hand. What's the first thing that has to happen? Stop the bleeding. What Mother Nature has cleverly done, or divine intervention, whatever you believe in, is the first cell to arrive at the site of injury is a platelets to stop the bleeding. What's the second thing that has to happen in that paper cut or tooth extraction or broken arm? Start the repair process. What Mother Nature's cleverly done is put the things that are needed for that second aspect in the same cell, the platelet. It then releases growth factors and starts the repair process. And since we'd increased the platelets by 10-fold, there's more growth factors being released, 10 times as many. And that's what was accounting for double the bone density and double the speed of maturation. And then we turned it at that time. At the first, we actually gave fibrin the star billing. And later we realized as important as fibrin is, the star billing goes to the platelets and has the platelet rich plasma. And so we started using for bone grafting. And then of course you can imagine for bone grafting, who are the guys that do bone? Orthopedic surgery. So it took off in orthopedic surgery. And from orthopedic surgery to sports medicine. Because you get a football player, a basketball player, you pay him $10, $50, $100 million, and they're out for the season. You're paying him money to sit on the bench, and you don't get your awards. And so now, if they can inject in the PRP, allow the body to heal, at least for the minor injuries, is he's not on the bench, he's playing, the team is getting their money's worth, and they're going on and getting their trophies. Sure. And so it took off in sports medicine, and then and from sports medicine, it took off into veterinary medicine. And veterinary medicine, the racehorses, the same thing. The expensive racehorses, is you can't have them get injured and not be able to race, or at least to go to a stud farm. You need them, as you can't just put them to sleep, and so able to inject. And then it took off from there to open heart surgery today, The complication rate for open heart surgery is decreased by 80% by spraying PRP in the wound closure. And then it went from there to diabetic ulcers, patients that have diabetic ulcers that don't heal for a year, using all types of creams, putting PRP on there within a month, getting healing on it. And then it went from there is Juvederm and Restylane, injecting it, to injecting in PRP. It's got to be a specialized form then, because you put the liquid in, it's going to squirt right back out. And so a specialized form of PRP is, and now it is a $40 billion a year industry. We had nothing to patent because it's Mother Nature. So there's nothing to patent on it. So we don't hold any patents on or anything. We have all the publications on it from those days.
Yeah.
And we held numerous symposiums. We first presented it in 1995 at a bone symposium in Palm Beach. And I just happened to find the brochure on that. We started doing a 3-day symposium dedicated to PRP in 2002, and just did the 18th year of it this year. As 3 days on just PRP. And now in the dental space in the US, there are 40 different centrifuge companies for PRP.
For just dental alone?
For just dental. In the medical space, over 200, I just call them spinners instead of centrifuge, 200 spinners for PRP. When I go to the anti-aging meetings and such, usually I find 30, 40 exhibitors with spinners there. Not all 200 that are in the space are exhibiting there. Usually 30, 40 at one meeting. Wow. Now, what each one will try to do in order to say their machine is better, their spinner is better, say ours doesn't make PRP, ours makes PRGF, ours makes PRC, PRD, PRE, PRF. You will get some of that. And so you get a little bit of alphabet soup these days. But it's always that middle layer.
Okay.
Yeah.
Stem cells and exosomes when it comes to dentistry. I've got a hypothesis on some of that, and that's actually how I got introduced to you on Last Minute, because I was interviewing Duncan Ross on the exosomes and trying to think through that, and so I can see why you would kind of cross over on that.
The stem cells is higher concentration than the PRP can give you.
So it has that potential.
Oh, absolutely, and a much, much higher concentration. Okay, so stem cells is the next level up.
Yeah.
Okay, and you say, well, if this next level up, is there still any use for the PRP? I use both.
Yeah.
I use both in combination, because the value then at PRP still is the handleability, which the stem cells alone, the liquid doesn't give. And the other thing is, it's got all the growth factors in it.
It's more of a wide gamut.
Yes.
Yeah.
It's like this would be taking a lot of vitamin C, the stem cells. Great, that will do a lot. Okay, but you don't need just a bunch of megadose of vitamin C. You also need the multivitamins.
That's right.
So the PRP gives the multivitamin. Okay, that would be the analogy.
That's a great analogy.